Welcome to the Pediatric Infectious Diarrhea Clinical Symposia Series presented by Johns Hopkins University School of Medicine at ID Care Live. Today is the second segment in a four-part educational series that will explore issues related to the evaluation and management of pediatric diarrhea. Today's session is titled Current Concepts in the Evaluation and Management of Pediatric Diarrhea, Is This Viral? With Dr. Stephen Pelton. My name is Dr. Elizabeth Barnett, and I'm Professor of Pediatrics at Boston University School of Medicine. I'm pleased to serve as the chair for this important educational program series. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce my colleague and today's co-presenter, Dr. Stephen Pelton. He's Professor of Pediatrics and Epidemiology at Boston University School of Medicine. Steve, thank you for joining us today. I'll now hand the program over to you.
Thanks, Elizabeth. It's nice to be here. Let me just begin with the traditional disclosure slide. I have investigator-initiated grants from Pfizer, Merck, and Sempra, and I serve as a consultant or an advisor to Pfizer and GlaxoSmithKline for their pneumococcal vaccine programs. Today's program focuses on acute gastroenteritis and asks the question, is it viral, and how do we approach the diagnosis and management of viral gastroenteritis? It's an important topic because on a global basis, gastroenteritis ranks as the second most common cause of mortality in children less than the age of 5. And although in the US we're fortunate that mortality is a small proportion of disease, we still have a significant morbidity with a lot of physician visits, emergency room visits, and hospitalizations. The clinical manifestations are pretty much straightforward with diarrhea and vomiting. Sometimes it's vomiting first and then followed by diarrhea. Sometimes there's minimal amounts of vomiting and profuse diarrhea. Fever, sometimes high fever, but more often fever is a small part of it. And the real issue is assessing the amount of dehydration and indeed developing an intervention strategy. Unfortunately, the symptoms for parasitic disease, viral disease, bacterial disease are overlap tremendously, and therefore it's hard to make specific diagnoses based on just symptomatology alone. Fortunately, though, the disease is often mild and indeed self-limited. Most children recover without the need for specific medical intervention, but we need to identify those children who do need medical interventions in order to prevent morbidities.
Steve, I wonder if you can comment on whether we still need to be so concerned about viral diarrhea, since in our country we now have rotavirus vaccine and have seen a significant decline in disease due to rotavirus.
Well, both in the US and globally, rotavirus vaccine has made a very important contribution to child health. We've seen a dramatic reduction in rotavirus disease in the US, and rotavirus disease was traditionally the most severe of the viral gastroenteritis that occurred in children less than the age of 5. So yes, in that sense, we've made significant progress. Rotavirus vaccine uptake is not as high as we might have hoped yet. It's still only in the 70 to 80% of children who are getting a full series, but we have made an impact. Unfortunately, we've started to recognize other viral pathogens, and I think everybody has heard the story about norovirus and the outbreaks that have occurred, whether it be in a daycare center, whether it be in a nursing home, whether it be on a cruise ship, and the both significant disease it produces, as well as the high rates of transmission and the large number of cases that are associated with outbreaks. So we've made progress, but we still have a significant morbidity and concern about viral gastroenteritis. Let me move on to talk a little bit about the pathogenesis. So in general, viral gastroenteritis, the virus directly attacks the intestinal enterocyte, leading to changes in the transudation of fluid and electrolytes, and that the process actually disrupts the villus architecture and then takes 6 to 10 days for a full recovery. There's a second hypothesis, at least for rotavirus, that it may be associated with an enterotoxin that alters calcium flux, and that's the mechanism, or one of the mechanisms, that alters the fluid electrolyte balance across the intestinal mucosa. However, the critical issue is understanding that you can have rapid fluid losses within a very short period of time, and that the need to assess the child, to establish a diagnosis, and to develop an intervention strategy is the essence of good management. This slide identifies the common viral etiologies. Rotavirus used to be the most common, associated with the most severe, but indeed in 2013, norovirus has now become the most common cause of viral gastroenteritis in children less than 5, and especially associated with outbreaks significant in daycare centers. Other causes are the enteric adenovirus and the astroviruses, which are significant causes in terms of the proportion of children. And then you'll see enteroviral disease. The important thing about enteroviral disease is more often not only are there gastrointestinal symptoms, but there are a spectrum of systemic signs and symptoms. You can have myocarditis, you can have aseptic meningitis, you can have pleuritis, all associated with gastrointestinal disease due to enterovirus, but you get these systemic manifestations. And lastly, parvovirus can be an important cause of viral gastroenteritis when it's present in the community.
So Steve, it sounds like there are a lot of diagnostic clues that come not just from the GI tract, but from a full evaluation of the patient and their physical exam.
Well, I would agree that there are basically 3 clinical approaches to trying to address the etiology of the diarrhea in a given child. The first is the epidemiology. So what's the age? What's the exposure? Does the child go to daycare? Are there other children ill in the daycare center? Has the child been traveling? Are there other family members that are ill? All are an important part of identifying what the likely etiology is. Then, obviously, the specific history and evaluation of that child. How long has the illness been going on? Has the child lost weight? Is the child urinating? Is the child making tears? Is the child alert and active, or is the child becoming lethargic and less active and less alert over time? I think that this is critical, regardless of the cause of diarrhea, for evaluating what interventions are needed, whether or not the child even needs to see a physician or a clinician, or whether the child can be managed over the phone with more standardized interventions. And then lastly, I think evaluating what the character of the diarrhea is. Is there gross blood or mucus? If there is, that almost always points you in the direction of a bacterial etiology, and indeed suggests there may be a role for antimicrobial therapy. With the absence of blood and the absence of purulent material in the stool would point more towards a viral etiology, and for viral etiologies there really is no role for antibiotics in terms of the usefulness of shortening the duration of illness. Again, the clues: severe watery diarrhea in the absence of mucus or pus suggests a secretory diarrhea associated with one of the common viruses. Blood and mucus, more likely an invasive pathogen: Salmonella, Shigella, Campylobacter, Yersinia. Systemic symptoms may be present, especially with either bacterial disease or